Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. Today, we are at episode 334, and my name is Terry Fletcher. So let's go ahead and get started. I'm going to talk today about a topic that actually I haven't talked about before, and I can't believe I haven't in over 330 episodes, and that's critical care. And I've had a lot of requests for it, talking about the inclusions, the carve-outs, what you can bill with and without it. And also there are some differences between CPT AMA and what CMS says about time. So let's talk about that and see what's going on. But first, the Codecast podcast is also brought to you by Select Coder. Get all the decision-making information you need to code in a single online resource. Select Coder offers you the comprehensive coding guidance required to code accurate claims the first time. To learn more about Select Coder, visit codingbooks.com/Select Coder. Okay, let's take a look at critical care. And the first thing I like to do when I talk about any topic is really get into the definition of the topic before we get into the coding of it. So we have the codes 99291, 99292, and what does CPT say about this? It says that it defines critical care as a critical illness or injury that acutely impairs one or more vital organ systems such that there is a high probability of imminent or life-threatening deteriorations in the patient's condition. So that means that the patient may be acute, but unless they are in a high probability of a imminent, which means very soon, or life-threatening deterioration, then it may not be considered critical care. So it says it involves decision-making of high complexity to assess, manipulate, and support vital organ system failure or to prevent further life-threatening deterioration of the patient's condition. So it's really to stabilize that patient that's, in the throes of a heart attack or in circulatory failure or in cardiogenic shock or in hepatic failure, something like that. So, and this kind of brings us to the vital organ systems: central nervous system failure, circulatory failure, shock, renal, hepatic, metabolic, and respiratory failure. So we always have to understand that first we start with the definition. And then Medicare addressing of critical care, does it differ from AMA? Well, with the exception of the add-on code 99292, they pretty much agree with each other. So how is a physician or QHP time and actually qualified healthcare providers or professionals, they are allowed to also provide this service as long as they are qualified. And I have found that in some TPE audits and some of the RAC audits, they do check to make sure they're qualified. But during the duration of critical care services, the documentation is so key because you first have to have the total time spent in that critical care encounter. So it's spent evaluating, managing, and providing care to that critical patient, as well as time documenting these activities. And you can't devote any attention to any other patient. That QHP or physician must devote full attention to that particular patient. And during each moment of this accrued time, it has to be either at that patient's immediate bedside or elsewhere on the floor or unit where that patient is, or immediately available to the patient, even if they're speaking with the family. So make sure that, that critical care accrual clock, if you will, it does pause when separately reportable services are performed. It's kind of like the time-based service we deal with E&M. Anything you carve out that has a separate CPT, you can't include in time for that service. So you can't include, certain things like A lines and CVP lines and things like that. So again, going back to the 99291 to 99292, total duration of time for those services, it doesn't have to be continuous, but it's on the same date and it's aggregated. So it's for that single date total time. That's why they took away where it had to be military time. So now it can be total minutes, but you make sure you have a physician who understands that they need to be able to support that gathered time for that day. So 99291, that's used once, a minimum of 30 minutes. of critical care services. It only can be used once per date, so you would not use that again. Anything less than 30 minutes, even if the patient is critical, would not be reported as critical care. You'd go back to the E&M code. I would assume most of them would either be in the hospital, possibly ER, or they might be a neonatal or pediatric, but the critical care codes are usually only paid in the inpatient setting. The reason I say that is because I've had some patients that, let's say, they're on a treadmill in a provider's office and all of a sudden they code, and they've been there longer than 30 minutes, and they call the ambulance, they take them over, and they said, well, we're trying to bill critical care in the office. You can't, because it's place of service designation, and you probably will get a denial, so you want to stick with that E&M code that day. So when you report that total duration of time spent by the physician or the qualified healthcare provider providing that service, non-continuous time, again, is aggregated for a single date, and time spent separately by the physician and the QHP can be combined, but it can't be duplicative. So you can combine it for that day, and it's similar to shared visits, where CMS also directs that the provider who furnished the majority of the time is the one who should report it, if that's how you're going to provide it. And if you're under the same tax ID, you have to do that, because again, 99291 can only be reported once. And so be very cautious about that. There's also been a couple of updates, especially for 2023, where you can't meet the halfway point. You actually have to meet the full amount of that time-based code. So for example, let's say 99292 can only be reported when the full 30 minutes of additional critical care time has been provided to the first critical care code of 99291 that's hit 74 minutes. It's 30 to 74 minutes, which is weird to me. If they say the first hour and they give you 30 minutes as the first hour, that doesn't make sense to most of us, but it has to go beyond that 74 to get that additional 30. So you would have to have 104 minutes total to be able to hit a 99291 and 99292. And there is a grid in CPT that you want to take a look at to make sure that you understand how that works. Also, if the critical care codes address services provided on that single day, what if it extends into another calendar day? Because let's face it, a lot of these emergent services, they actually happen on, over the midnight period, because the patient comes in late or goes to the ER, and then all of a sudden they're going to be admitted, etc. So CPT coding principles require that when a time-dependent service is performed continuously and it crosses over midnight, the time should be accrued for and reported as occurring on the pre-midnight date. So now once the service is disrupted, so it becomes non-continuous, then that creates a need for a new initial service on the post-midnight date. So let me give you a couple of examples so you can see the contrast. So for example, how would you code a patient who presents to the emergency department at 23:35 on day one with critical care services beginning at that time and performed continuously until 15 minutes past midnight on day two, with no more CC services performed on day two? Well, that's 40 minutes that was provided crossing over midnight, so you would only report 99291 for day one because it's 30 to 74 minutes. But how would you code a patient who presents to the emergency department, again, 23:35 day one, with CC services beginning at the time performed and continuously till, again, 12:15 a.m. on day two, at which time continuous CC services are interrupted, and then they are reinitiated at 1:30 a.m. day two with an additional 65 minutes provided on day two following the reinitiation of those services. So you would have 99291 day one, and the second would be 99291 for day two. But your documentation better demonstrate that those circumstances changed where you had to reinitiate critical care and there was a disruption. Otherwise, you will absolutely get hammered on that through audits. And when looking up the 2023 and 2024 CMS fee schedule, they agree with CPT on that time element. So what are essential documentation requirements for the use of critical care codes? Again, 99291 and 99292. So providing medical care, they first have to meet that definition of a critical illness or injury that I mentioned before. and that medical record documentation must provide that substantive information. Total critical care time must be delivered and must be at a minimum of 30 minutes, exclusive of any separately reportable procedures or time of those procedures, and you want to carve them out. Now, if there's a teaching facility or teaching physician criteria, time spent alone by the resident, again, performing critical care activities in the absence of a teaching physician, cannot be counted towards critical time. Only the time spent performing critical care activities by the teaching physician can be counted by that. So just make sure you understand that. The teaching physician may tie into the resident's documentation and may refer to the resident's documentation for specific history and physical findings and assessment, but the teaching physician must still document the statement of the total time they spent personally providing that critical care time. That's why critical care and that critically ill patient, when you get that it's so high weighted when it comes to reimbursement. They want to make sure that it's more than just management by the teaching physician, that they're personally providing that critical care services. CMS gave us a vignette of what would be acceptable documentation in that situation. So patient developed hypotension and hypoxia. The teaching physician, spent 45 minutes while the patient was in this condition, providing fluids, pressor drugs, and oxygen. I reviewed the resident's documentation, and I agree with the resident's assessment and plan of care. There's also a transmittal on this when it comes to teaching physician criteria, and it's transmittal 1548, so make sure you take a look at that when you need to. So there's been a question that comes up, says, can a critical care service be reported with a different E&M code for a non-Medicare patient cared for by the same physician on the same calendar day? So CPT allows for the reporting of some services, and I'll give you some examples in a minute. And additionally, CPT does not distinguish as to site of service for which comes first, and some payers require the 25 modifier to be attached to the non-critical care E&M. So I wouldn't put the 25 on the critical care code, because even though it's in the E&M section, it's considered procedural. Now, there is a question that always comes up. Patient starts in the ER. So can we bill for, let's say, a 9928 code with critical care services on the same day? Well, for Medicare, they disallowed this. You could not report the 9928, whatever the level for ER, and critical care on the same date. Okay, that was prior to 2022. But as of 2023, CMS now has a policy that allows the reporting of critical care as long as it's provided after the emergency department E&M service is complete, but not the other way around. So let's say a Medicare patient presents to the ER department, receives an initial emergency department workup supported by the codes 99281 to 285, and then later, they're still there under observation, then later on the same date, requires critical care services. Well, can you report both the ER service and the critical care if you're under one umbrella, meaning that your physician or qualified healthcare provider is billing for this? It's not an ER doctor plus your doctor. So if it's an ER doctor and then your doctor, different tax ID, it's not even a question. But sometimes the critical care doctor, whether it be primary care or general surgery, they want to bill for both. So it says if a patient received critical care services upon arrival, then an ED E&M may not be reported by the same physician in the same group or the same encounter if additional ED services are provided after the patient is stabilized. So it has to be after and in a separate encounter, but not at the same time. So separate encounter, you're okay. Otherwise, one will get kicked out, and typically it's the ER visit. So what's bundled into critical care? What do we have to carve out of that? Can't use it as part of time, and they call it included in the critical care clock time, meaning that it can be, that can be provided during the critical care by the same physician and should not be reported separately. So what's included? So if you do any kind of interpretation of cardiac output measurement, sometimes we see this in cath, pulse oximetry, chest x-rays, the professional component. So the professional component of 71045 and 71046, that's actually part of critical care. Blood gases and management, gastric intubation, so you can't code separately the 752, 73753, any kind of transcutaneous pacing, vent management, vascular access. to just, stick the patient for that. You can't bill any of that separately. Those are going to be bundled into critical care. So make sure you're aware of that. Otherwise, there could be an issue. Now, does Medicare differ from CPT in addressing critical care services and bundling procedures? Medicare bundles the same services that CPT does, but starting in 2022, remember, CMS did require the FT, so F as in Frank, T as in Terry, modifier to be appended for procedures with a global period and a 25 modifier for an E&M service unrelated to the procedure. So what can you bill separately from critical care? So notwithstanding what I mentioned, what is included. So this is from the critical care accrual clock. When you perform these services, and you can bill them separately, so you can't include these in time. So CPR, while being performed, okay, which surprised me. I figured that would be included. Endotracheal intubation, central line, tube thoracostomy, temporary venous pacemaker, electrocardiogram, routine ECGs, elective cardioversions. It's not the total list, but you can just see that as part of a list that explains that those are separate. And there is a list in CPT about that. And then CPT does not require the use of the 25 modifier when billing critical care services and non-bundled procedures. However, critical care services provided to a patient may not be paid by some commercial payers on the same date that somebody else also bills a non-bundled procedure, unless you put a 25 modifier on it. So I mentioned before, the 25 modifier is really for an E&M that's not a critical care. Some of your third-party payers, I know, for example, United Healthcare, for example, if you did an endotracheal intubation, 31,500, or if you did CPR, 92950, if they're provided, I've noticed that they do want the 25 modifier on critical care, and then they will almost automatically review it and ask for records to make sure the time is there, to make sure the patient was actually critical. The CPR should have given them information that said it was, but it was just interesting that there's certain payers that definitely want it. And just going back to that CPR and critical care at the same patient encounter, both Medicare and CPT do agree that as long as respective requirements for each services are satisfied and evident in the medical record, both can be billed. So that 92950 for CPR, it's a non-E&M services. It includes chest compressions, adequate ventilation, the bag valve mask situation, and it can be reported with critical care. Just remember that CPR time cannot be counted toward that critical care time itself. And then the last thing I'm going to say on this one, as far as dealing with your split or shared service rules involving physician assistants and nurse practitioners, new language under the CMS for the shared visit between the PA nurse practitioner and the physician, to allow the total time between the providers to be combined, and whoever furnished the majority of the time is the one that reports the critical care codes. So make sure that's right in the Medicare Manual 30.6.9 and 30.6.12. Remember to include that time. Remember to include what services each provider provided, and you'll be good to go. But critical care, it can be a little bit tricky if you first don't read the directions in CPT and then make sure that you follow up with what Medicare says. Otherwise, you could have some payer issues there. Okay, for my personal tidbit, I'm just going to put out a public service announcement. Get out the vote. Regardless of your affiliation politics, you need to vote if you have any problem with what's going on in the country right now, or if you don't, even if you like what's happening. But if you have some reservations and you want different leadership, get out and vote. I voted today. I'm sure most of you know which way that was, and it's the primary. So we need to figure out, it's for your local policies where you live, and then what gets on the ballot for the general election this November. So get out and vote. All right, everyone, make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.